Thank you, Ms. Doctor. Ms. Kent, well, it's a good thing that you're batting cleanup because there are lots of questions asked, and I certainly don't have any answers. I suspect that you do, and if you don't, you're going to tell us how we get to those answers.
Sure. Thanks so much. Mary Cantwell, Chief Deputy, Department of Healthcare Services. I apologize, Assembly Member. I feel very awkward. I know I do. It just feels very awkward for me.
Just in case, more than happy to share the real estate over here.
So obviously there were lots of questions raised here and lots of questions raised in the agenda. I really appreciate the information that everyone here shared. I just want to first, before I get to answering the questions, just be really clear that the goals that certainly have been laid out in terms of what the intention of CCI was, and in particularly CalMediConnect, and really the excellent description of the fragmented system that people have had to operate under when you have two very separate systems providing your health care, and the goal really being how do we do that better. Certainly, there have been challenges in the implementation, and we acknowledge that, and we really actually appreciate everyone at this table who has worked with us to try to figure out how do we do this better? How do we improve what's happening? And how do we start to really see the change that we were hoping to see? So we remain committed to the program and to continuing to work with the legislature, with our stakeholders and our health plans in determining how is it that we can improve the program, both in enrollment, as was mentioned, but also making sure that the reason people are enrolling is because the care delivery is better than what they would be experiencing without this program. So I'm going to touch on a few of the questions that were asked of us in the agenda, and I think I cover several of the issues that have been raised here, but then certainly am open to additional questions, and I know my colleagues here from Department of Aging as well as Social Services and Department of Finance also have comments that I'm sure that they would like to make. So one of the first things that was asked of the department to talk about was evaluations of the program. So there are currently 2 external evaluations occurring of the CalMediConnect program. In particular, the first is the national evaluation that's being conducted by CMS in contract with RTI International. The CalMediConnect program is just one of several dual demonstration programs happening across the country. And so this is really the national evaluation. Really what the evaluation is looking at is beneficiary experience, quality, utilization, and cost. And there's going to be an aggregate evaluation as well as state-specific ones. What RTI is doing is collecting qualitative and quantitative data, reviewing claims data and enrollment data, as well as conducting site visits, focus groups, and key informant interviews. Information from those activities will be reported in an initial 6-month report to CMS, quarterly monitoring reports to CMS, and then annual reports and a final evaluation report. The second evaluation is California specific. It's being done by the SCAN Foundation, and they have funded 2 separate projects. The first being a rapid cycle polling project, which is evaluating the enrollment process, and the second is a 3-year longitudinal evaluation that's going to be designed based on some of the information that's being accessed through the Rapid Cycle Polling Project. The Rapid Cycle Polling Project is a telephone survey, and they will be selecting a random sample of participants, both those in the program, those who opted out, as well as individuals from non-CCI counties. And it will be a telephone survey that will start to be conducted this spring. We're also working, there was mentioned that there isn't a specific evaluation for the managed long-term services and supports, and that is true, but we are currently working with an organization to do just that evaluation of just the MLTSS component. It would be looking at utilization, patient characteristics, and rates of institutionalization, both pre-CCI and post. And we'd also be looking to include measures of patient experience, changes to how services are provided, as well as the use of alternative services. Besides evaluations, there are a lot of metrics. Certainly appreciate and acknowledge that getting the data out there can be challenging, given both data lags and all of that, but we are working to try to get as much information out there as we can. In terms of monitoring, there are 100 quality measures that we're looking at in CalMedi Connect. These include things like readmission, care management goals, follow-up after hospitalization, ensuring physical access, and things of that nature. Several of these are metrics that are tied to health plans receiving what is called a quality withhold. If they don't meet the established benchmarks, there is funding that they do not receive as part of their capitation rate. So there is a financial incentive built in to try to increase the quality. Separate from those, we do monitor our health plans regularly, ensuring that care coordination is occurring. Plans are required to provide care coordination services, and the level of that depends on the level of acuity of the member. We also have our monitoring of grievances and appeals and our annual medical audits that we're doing. As was mentioned, health risk assessments are a key part of what the health plans are required to do. This is true both in CalMedi Connect as well as for our Medi-Cal only population. The timeline of when those health risk assessments or HRAs depends on the program. And through those, that is what the plans utilize to determine individual care plans and whether an interdisciplinary care team is necessary. And in both cases, a member can request either of those, even if they were not determined by the health plan to need one. In these, what happens is the care plans have what are the members' goals and objectives, what are the measurable timelines that are going to be updated, and how to coordinate the services that aren't a part of the health plan's responsibilities. Recognizing that you like me to be short, I will keep going. With respect to IHSS and CCI, as was mentioned, the program in and of itself operates pretty much similar to what it did outside of managed care. So for the member, there wasn't really disruption. They got to keep their same provider. We do have a survey that we'll be releasing to your committee staff and certainly to the public of how many individuals have been referred for additional IHSS hours. Based on the information that we've received from our plans so far, we believe that's over 10,000 individuals have been referred for additional hours, and it looks like about at least 5,000 have received additional hours. And again, that ranges across health plans and across individuals in terms of the amount of that, but we'll be providing those detailed survey results to the committee and obviously posting that on our website. And then there was one final question in the agenda about how we define sufficient access for MLTSS services. Just like all other services, health plans are required to have an adequate network. When we talk about the integration of MLTSS, that's really three benefits that were integrated into the health plan. IHSS, which as we talked about, really stayed the same and individuals were able to access their provider that they already had. MSSP, which has been discussed, and long-term care facilities, although for two of our 7 counties, long-term care facility services had already been included in the health plan prior to CCI. For MSSP, plans are contracting with all MSSP sites, and for long-term care facilities, again, our health plans are required to make sure that there are sufficient providers to provide the necessary long-term care services. But we also, separate from that, have a continuity of care requirement that says if a member is in a long-term care facility, they have the right to continuity of care to stay in that facility, even if it's not a contracted facility, as long as there aren't any quality of care issues with that facility. So I will stop there and see if you have any, Ed, if you have anything, or also there were other administration folks who I think had some comments.
Okay, sure. Hello, Ed Long, California Department of Aging. What I can speak to with regards to some of the questions and points that Mary raised really has to do with our role through our interagency agreement with the Department of Healthcare Services for waiver oversight and oversight of the CBAS program as well as the MSSP program. Under our interagency agreement for MSSP, our responsibility is to ensure that the state meets its waiver assurances under its 1915C waiver for MSSP. So we do monitor to a number of different issues relative to the waiver having to do with level of care, the service plan, care coordination, qualified providers, the health and welfare of people enrolled in the waiver, and financial accountability. And so to the degree that one of the questions had to do with how are consumers faring under MSSP as CCI implementation happens, from our perspective, MSSP sites continue to do what they're supposed to do in providing waiver services to MSSP enrollees who are also plan enrollees at the same time as they're working on some of the operational issues that have already been raised. And our role has really been to work closely with MSSP sites, managed care plans, the Department of Healthcare Services, and others to try to identify issues, float them forward, and work on resolution. That is a role we will continue to play as CCI rolls out. Under CBAS, we also have an interagency agreement for program oversight for the CBAS benefit. We administer the CBAS program via an interagency agreement with DHCS, the Department of Public Health, and the Department of Public Health, and we are focused on Medi-Cal certification, the Department of Public Health licenses.
Before we get into that panel, since we'll be discussing that in the second panel,
okay.
I'd like to ask if you could just make a few brief remarks about the current issue about CCI, because then we're going to take public comment on CCI as well.
I think as far as CCI implementation goes at this point in time, I think I want to acknowledge that we continue to work closely with DHCS, MSSP sites, and managed care health plans to address operational issues, particularly right now as they pertain to payment and data exchange with relationship to people enrolled in CCI and the managed care plans.
Thank you. I know that we might have just a comment or two from folks from the Department of Finance, Yang Lee and Scott Ogus. You might have to make some room at the table for them if they are prepared to make remarks. Will you be making remarks, or are you available just for questions?
I have some remarks to make.
Come on up. Come on up. Yep. Don't go far. We'll bring you back for your questions. Don't worry.
Can I go?
No, you got to stay. You know that you never get to. You get to leave when I get to leave. How about that? Go ahead, sir.
Thank you, Mr. Chair. Scott Ogus with Department of Finance. In answer to question 1 on the agenda regarding the cost-saving situation, SB 94 from 2013 requires the Department of Finance to annually assess the statewide cost-effectiveness of the CCI program. If the program is not found to be cost-effective, the state is required to cease operation of the program. Our 2-year analysis provided with the governor's budget projects a net general fund savings of $173.9 million in 2015-16. However, our multi-year analysis shows the program would result in net general fund costs in 2016-17 of $35.4 million. There are various factors contributing to these costs, some of which have been mentioned already: the opt-out rate of dual eligibles enrollment into CalMedi Connect, the federal disallowance of the managed care organization tax, the current managed care organization tax, and growth or changes in the IHSS program that, because of the county maintenance of effort requirement implemented with CCI, lead to increased general fund liabilities. All that being said, the administration is committed to implementing the program to the extent that it continues to generate general fund savings. And to that effect, we are working with various stakeholders to increase participation in CalMedi Connect, to extend the managed care tax, and lower other state costs so that savings may be realized over the multi-year forecast horizon.
Thank you, Mr. Ogus. And is there anything from the LAO's office on this, or are you available for questions?
We're available for questions, Mr. Chair.
Thank you. Any questions from the committee? Mr. Bonta.
Thank you all for your presentations. Just a quick question for the department. Does DHCS have a target for CalMedi Connect enrollment? And is there a specific target you need to reach in order to decide whether or not you're going to be supportive of the continuance of the demonstration?
Sure, there is not a specific target. I think as my Department of Finance colleague mentioned, we're generally looking at all of the various reasons why it's possible that the program wouldn't be cost effective as required under the statute. But what we're really focused on is understanding why are people not enrolling at the levels that we had hoped? And how do we make the program better? How do we help educate people better so that they can understand what the potential benefits are? But there is not a particular target for enrollment. Obviously, the statutory requirement is that it be cost effective. But as was mentioned by Mr. Ogus, that there's a lot of factors outside of enrollment that affect that.
Mr. Chair, may I? Are you currently engaged in any efforts to better educate and encourage dual eligibles to enroll? Or are you sort of assessing where you are first? Are you sort of in an assessment phase, or are you also concurrently in an action phase as you continue the assessment?
I'd say it's concurrent with more of the focus right now on trying to better understand. My deputy director for healthcare delivery systems, who is over this project, has been convening a task force of probably several of the people who you heard talk today, as well as our health plans, to help us understand from people who are on the ground what's happening, what are the concerns. Is it that there's a problem with the program and we need to increase that, or is it that there's a lack of understanding about what the program is offering? But at the same time, we are working with our health plans. As was mentioned, the CCI has as a component that even with the opt-out of CalMedi Connect, these members are enrolled in the health plan for their long-term services and supports. So we're really working with our health plans and encouraging them, and they are permitted to under federal rules, and this was something that was just clarified, that they could actually be reaching out because these are members that they have, and so they already are reaching out to them about their services and at least providing some additional information about the benefits of CalMedi Connect.
Thank you.
You're welcome.
I'd like to ask a question to Ms. Likar and Ms. Cutler and possibly to Ms. Steenhausen. But Ms. Likar, if you would first. You gave a great profile for me anyway about what a patient or consumer situation might look like. You mentioned age, co-occurring conditions, and some psychosocial needs. That was very helpful to be able to contextualize what it means to be dual enrolled and what it means to be in these programs. I wanted to push a little further on that and invite others to comment on it. The folks who are in the CCI, did they know that they're in the CCI? And do they? Because this sounds so complex. Like, if you sent me this letter, I would not sign up for it. I would not. I just want to understand, how do the people that we're trying to help while also maintain these savings feel about this? Do they know that they're in the program? And share with. I can tell from your reactions you've got some thoughts on this.
I'll start with me. No, I don't. I think by and large, having adopted a passive enrollment process into a program that's not proven yet. So you have a product that you're pushing that doesn't have any proven value at this point. So you have a lot of members who get enrolled into a program not having realized that they've been enrolled into a program. And then you have a large number who have decided that this program wasn't for them because they've cobbled together their care in such a way that makes it work. And I think the old adage of the devil you know applies here, that it is much safer for them to keep their care the way it is and not take the risk of joining a new type of health plan that's unproven, that they keep their care the way it is. Even with that said, they're still being mandatorily enrolled into a Medi-Cal plan, and that's very confusing. Understanding what that Medi-Cal plan is responsible for can be very confusing and can also lead to disruption in care, even though technically it shouldn't. In practice, it has been. So to answer your question, do they know that they're enrolled in the CCI? Absolutely not. There's absolutely nothing that says this is a coordinated care initiative. There are different parts of the program, so they might get a CalMedi Connect notice, or they might just get a notice that says Medi-Cal Managed Care. But as Sarah's presentation, which was at the most high level, points out, it is incredibly complicated transition in care. So it is not surprising to me that there would be so many people who would want to keep their care the way it is.
And Ms. Cutler, you mentioned that there was a disincentive for folks in certain groupings. I didn't catch all the letters that you said, IPG, APG, ABC. I couldn't keep up, but what I did hear is that sometimes people would be told you could no longer continue with the provider in your network. Right. That did get my attention.
Yes.
How does that play out with the patients and the consumers? And then I'm going to ask Ms. Cantwell and others, how do we fix that?
Right.
Because it seems like if we're doing this to make care better and more cost effective, we wouldn't want anyone to have to lose a provider.
Exactly, which is, I think, a major part of the Coordinated Care Initiative would be an expansive continuity of care policy, and one where they would have major access to providers, because moving into managed care means that you're narrowing the availability of providers, because in the fee-for-service world, you can go see any provider who accepts your health insurance. The very movement into managed care means that you are limiting people's access to see their providers. The policy that's currently being drafted or is currently being proposed is that plans would not only limit them by having a planned provider network, but within the plan, they have other networks that are independent physician associations. So I called it an IPA or a PPG, a preferred provider group. Acronym soup. So if you get assigned to one of these IPAs or PPGs, then that's your network, despite technically, the entire plan should be your network.
So if you don't know that you've been assigned to an IPA or a PPG, which I'm going to forget right after I said it,
right.
How do you disenroll? You mentioned that people were disenrolling. How do you disenroll if you don't know you're in
what happens is they find their way. There are several things that happen, I think, but I think the primary thing that happens is that they find themselves to an advocate who tells them, well, in order to maintain access to your provider, you can always disenroll, and that will allow you to continue to see your Medicare providers fee-for-service.
So they find themselves to Ms. Doctor, who helps them to, or
the CCI ombudsman.
Yeah.
Go ahead, Ms. Doctor.
There's a great organization of ombudsmen and other advocates who are doing their best to help people. But going back to this issue of losing the provider, which I believe must be the main reason that people are opting out, back when you were blissfully still in Richmond, not up here, when
you still live in Richmond.
Yes, I know.
Well, I live on the train, but I...
Yeah, I understand, yeah. The idea was people were told, well, if you want to find out whether you can continue to see your doctor, all you have to do is call the plan that you're considering being part of. But now we know that that wasn't the real way to find out whether you could see that doctor, because nobody knew to ask, is my current doctor not only in your plan, but in the IPA or PPG that I'm going to be assigned to? There's another issue here, because as Amber said, we're talking about a narrowing of available physicians and specialists or whatever. And when Amber talks about less access to care, she's using that term in the generic access. But I want to talk about disability access, because we know that there are very few providers who are fully accessible, physically accessible, programmatically accessible. And when you narrow the list further down of people that someone can go to, and accessibility is not one of the reasons that you can get a continuity of care, insofar as you're limiting it to the general population, you're possibly limiting it even further for people with disabilities. Thank you.
Thank you.
So going back to my picture of our client, and what we have seen from day one is, because these people are compromised, because a lot of them cognitively impaired, some of them may have family and friends helping them, but everybody is overwhelmed around this person's care and trying to keep it together. And with all of the mail that was coming in, my site's a great example. The first month of the CMC enrollment process, we had a whole cohort just at my site alone that our phones were ringing off the hook, and they said, I didn't know about anything about this. They'd been on hold for hours. And so not knowing and not a clear way when they reached out to those health plans that they were now members of, it wasn't, and I know these are part of the startup issues, but really being able to get that information, they just started opting out. I mean, so we saw lots at our site where they were asking our care managers to help just get me out of this. I was on the phone for an hour and I couldn't get to somebody, and I can't deal with this. I'm scared. And so there's a lot of that fear as well with all of this, especially when you're compromised and you're dependent on the system. And they're going to look to the resources in the community that the faces that they know to say, help me. And we don't have a better way. So it's like, all right, we'll do what we're going to help you get what you want, because this is your choice. And that's where we've been working a lot of our staff's energies in the community, saying, okay, so let's look at your choice.
Is anybody saying at CCI we shouldn't be doing it? Or are you just saying fix the problems of implementation?
I'm saying we understand that healthcare is going in such a way that we need to be open to the new world to take care of these folks, and we're willing to collaborate. We're willing to work together, but everybody's got to be willing to collaborate, work together. There has to be a strong leadership over that, and we need the proper time to set up and do what's right for this population that we serve.
Ms. Cantwell, everyone was pointing to different fixes around enrollment and the system in general. What say you?
Very broad question. I was ready to talk about the delegation, but I'll do that. As was laid out very well, we do live and operate in a state where health plans broadly, not just in Medi-Cal, have a much higher rate of what we call subdelegation, which is what the IPA, PPG conversation is about. And it actually does vary widely across the state. When you go to Southern California, it's a much more highly delegated model, so you have much more of the situation that Ms. Cutler was laying out in terms of being enrolled in not just the plan, but also a subcapitated entity. Northern California, it's less that. And across our whole Medi-Cal program, so essentially you go from 0% delegation to nearly 100% delegation, depending on the health plan. We don't necessarily think that delegation is a bad thing. I think as you've heard me talk about in other hearings, when we look at our 1115 waiver, we're trying to look at how do we pay for value? How do we start having providers and others have some level of accountability to not only their beneficiary, but to each other, to figure out how to work better together. And that's what the goal of delegation really is, to put down at a lower level the responsibility for the care management. And so certainly there have been challenges, and we understand that. I don't think we're at a position right now to say that not having delegation is the right answer, because again, we do think that having a lower level responsibility for overall care management is important, but making sure that people understand what are their choices. How does the network actually look like when you are in a delegated model, and understanding that one, you can change you can stay in the health plan and change which provider group you're with, or as has been happening with CalMedi Connect, you can also choose to disenroll from that. And so we're certainly happy to work with folks to make sure that there's better materials out there to explain the networks, also explain better to the degree that it isn't clear what the continuity of care availability is, because certainly no one should be not receiving care from the provider that they want to see, and plans do have to pay for that for a period of time, even if they're not contracted with their provider.
I want to ask you this. What is the Department and the Governor's commitment to CCI given the mixed results around cost savings? And if there's commitment to this long-term, ongoing, what is the commitment to fixing the things that have been the snags that are causing the cost savings to not be achieved, as well as the difficulties in the actual delivery of the service?
Sure. So I think, as my colleague from the Department of Finance said, we certainly are committed to this. We wouldn't have put forward this proposal originally several years ago if we didn't believe that moving in this direction of coordinated care, hence the name, was the right thing to do. And certainly, as I mentioned at the beginning of my comments, there have been challenges. And so we do have a statutory requirement to have it be break even. It's not an option. The Director of Finance does have to do an actual fiscal analysis, and by statute is required to make that determination. But that's why we're doing all we can, both at our department and our sister departments, to help make sure that the program is working the way it should. And so we're certainly open to, and hopefully folks have found that to be the case, but working with the folks at this table and others to help make sure that the program is operating within its intended goals.
I'd like to hear from the public. If there's any public comment, we'd like to have you come forward. 1 minute each, and I'd like to ask if we do have a microphone. 1 minute each, please. Thank you.